Okay, wonderful. And we're so glad to welcome Dr. Jocelyn Jiao as our main speaker for our Palo Alto Parkinson support group today. Dr. Jiao is both a movement disorder specialist and a palliative care specialist. So that is a wonderful and unique combination. And we are glad to welcome her back to our group today to talk about caring for the whole person with Parkinson's disease. So if anybody has questions, please put them into the chat or the Q&A. Both Denise and myself will monitor those and take it away, Jocelyn.
Thank you, Robin, so much for inviting me to come back and speak with this group. I'm not sure if the people here were here the last time that I came by, but I'm really delighted and honored to be able to join for these couple hours with you this afternoon. Like Robin said, I'll be speaking about caring for the whole person in Parkinson's disease from the perspective of palliative care and movement disorders. And we'll get started. So when all of us kind of think about our whole personhood or, kind of living our best life, I imagine that many people are thinking of scenes much like these, eating good food, eating pizza, particularly going on hikes, spending time with family, attending sporting events, potentially even things like participating in our church communities, our spiritual communities, and caring for loved ones and pets. As a neurologist, as a doctor, as a Parkinson's specialist, I often see that illness can get in the way of that whole person. Illness can get in the way of us living our best lives. It can introduce uncomfortable symptoms that can affect us physically. It can introduce to us big questions about what's going to happen to us from a psychological and an existential way. And illness can affect us emotionally, financially, those practical aspects of life as well. So there's so many ways in which illness makes a huge impact on not just the body, but the whole person. I'm here today to talk to you about an approach to a serious illness that can bring back some of that joy and highlight meaning and satisfaction for people for whom they feel like illness is affecting the totality of their lives. I'm here to talk about palliative care. And as a part of that, I wanted to just describe the roadmap of what we'll talk about today. I'll start with just giving some definitions. What is palliative care? How is palliative care different from other parts of medicine? When and how can someone benefit from palliative care? And how does palliative care help people live their best life? And I'll also finish by talking about the difference between palliative care and hospice. To start us off, I like to usually ask the group, I'm not sure if people can unmute themselves in this context, but you can also put in the chat, what is palliative care? What have you heard about it before?
People can definitely put it in the chat.
As you're doing that, I'll, read out some of the things that I see. Goals of care. Thank you, Carmina. Many people often will volunteer and say something that they heard about that it might be helpful for end of life and comfort. I see Jenny wrote not same as hospice, deals with symptoms. Denise, thank you, support for the family. Good to see you here. I think all of those are really some fantastic ideas behind what palliative care can be. And certainly it does continue and contain all of those things. So thank you for answering this question. What comes to mind for you? For us to kind of approach this question of what is palliative care, I like to kind of take a big step back and really emphasize this one point. Palliative care focuses on the person beyond the disease. While many of the people taking care of you all obviously care about you and your family as people, I really want to emphasize this is really the focus of our work. This is the absolute thing that we obsess over, the individual. And how does palliative care, differ from other teams? We take a holistic approach to illness. So of course we consider the person and their family in the center of this diagram as the center of care. But we also consider all the ways in which illness can impact multiple aspects of life. So yes, thinking about how it can physically affect people and how people can physically suffer, but also we think about how the mind can be affected, how the spirit can be affected, and how the practical aspects of life also reverberate with the consequences of a serious illness. This holistic approach, can certainly be seen in some of the other modes of care that you might encounter in your different clinics or the different teams you might work with. But this is also a foundational aspect of a palliative care team. When you first show up to a palliative care team, we actually have multiple people who hopefully will join for that initial visit. And that's because we do recognize that there are multiple aspects of life that can be affected by illness and Parkinson's disease. The doctors and nurses, the medical team can certainly prescribe medication, help with medical decisions, can help coordinate your care with other doctors. The social worker is really there to provide emotional support to both the individual living with the disease, as well as the people important to them, their caregivers, their care partners. They can be helpful with connecting you to medical equipment or helping you access financial resources that might be a benefit to you. The palliative chaplain holds such a special role on our team. They're really there to hold space for those big spiritual questions, those existential questions. Often when people ask me, in clinic, how do I make sense of this? How do I make meaning in my life now that it looks so different from how I thought it was going to look? Or why is this happening to me at this point in time? I often think that beyond offering, prayers and blessings, palliative chaplains can be a wonderful source to really help people process those big existential and spiritual concerns that are very common for people living with this serious illness. So we just, talked a little bit about some ways in which palliative care might be a little bit different from the other kinds of doctors that you've worked with. And I want to go through a specific definition of palliative care. So this definition, I'm going to read it through and we can break it down. Palliative care is specialized health care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and the stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specially trained team. Palliative care specialists work together with a patient's other doctors to provide an essential layer of support. And palliative care is based on the needs of the patient, not the prognosis. It is appropriate at any age and at any point in a serious illness and can be delivered alongside curative treatment. When we think about living with a serious illness, a lot of people wonder, what does that term really mean? So this is just a short list of some of the common diagnoses for people that I see in my palliative care clinic. Certainly, I see people living with cancer, with heart failure, Parkinson's disease, dementia, and ALS. And there are many other conditions and diagnoses that are not listed here. Often, for a palliative care team to get involved, it's more based on the needs of the individual and their family and less on the specific diagnosis. When we think about relief from symptoms from palliative care, here are some of the common Parkinson's disease symptoms that I manage in my clinic. There are many physical ones that might be common, such as pain and constipation and muscle spasms, increased saliva. And there might be more psychological symptoms like agitation, anxiety, depression, and then other kind of more difficult even to define issues such as coping and fatigue, low appetite, and the stresses of caregiving. So how do we approach symptoms in palliative care, and how is it different from potentially how other modes of medical treatment might approach it. Let's take a case example of someone in my palliative clinic who has Parkinson's disease and is telling me they're having trouble sleeping. So when I think about this person and their sleep, I'm trying to consider several different factors that might be impacting their sleep. They could be, yes, experiencing a side effect from one of their antidepressants that's keeping them awake, but they also might be staying up worrying about their recent weight loss. And what does that mean? During that time in which they're awake, they might sleep in a little bit later than they mean to, and they might miss their grandchild's soccer game. And because of that, grow more distant from the people important to them. And while they're awake and worrying throughout the night, they might wonder, is this a punishment for anything that I've done? How can I make sense of what's going on right now? How did I get here? So often in palliative care, we want to approach the physical symptoms. We want to think about the role that medications can play, but we also want to think about psychological interventions, ways of reframing a situation using cognitive behavioral therapy techniques. We're also open to integrative techniques like acupuncture or massage, or even medical marijuana for people who have some complaints that can be addressed by those. And we certainly never want to forget about the spiritual side of illness and suffering, and make sure that people's spiritual and existential concerns are also being addressed. Palliative care can also help with medical decision making. What that means is, yes, we can help you go through the paperwork that often lawyers will give you when you're doing estate planning, those advanced directives, help you fill out a post if necessary. We can also help you weigh the burdens and benefits of different treatment options. And this is honestly my favorite part of my job, helping people think through what makes sense for them based on what's important to them as an individual or them as a family. Some of the common treatment options that I'm talking people through or supporting families as they decide might be, is it time for us to think about a feeding tube? Where is the best place for my mother to be? Is it at home? Is it in a facility? And what kind of facility would that be? And then also, people ask me all the time, what do I do? What are the things that I consider as time is growing short? And what are the ways that I can really help my loved one have as good a quality of life for as long as possible? So this piece is really, I think, the heart and soul of palliative care, and the piece that's drawn most of the people that I work with to this field. And like I said, again, I can't overemphasize enough. It's my favorite part of my job. One thing I like to really emphasize as well is that palliative care is appropriate at any age and at any stage, and can be provided alongside any type of treatment. Some examples of people I see in clinic, I'll see people with a new diagnosis. I'll see people who are pursuing treatment, people who are enrolled in clinical trials, and certainly I'll also, of course, see people who are living with their illness and working to thrive with that and not receiving any treatment targeting their underlying illness. So anything from diagnosis from that point onwards, I can really see people for. In palliative care circles, we have a joke that if it were a pill, we would be the next blockbuster drug. And that joke really is stemmed out of this really important study that was done in 2010 for people living with advanced lung cancer, in which one group of patients received early, meaning from diagnosis onwards, regular outpatient visits with the palliative care team, and one group did not, the standard care group. What this study showed is that people who received palliative care lived longer than those who did not. This is usually a pretty surprising graph for a lot of people when they consider palliative care, and certainly when it came out, this was a landmark study because it did break with a lot of the expectations that a lot of doctors and providers have about palliative care. In the many studies since, palliative care has been shown to have many benefits. We've seen studies that have shown that it improves quality of life, symptom control, spiritual well-being, psychological symptoms, and overall satisfaction with care. And we also see kind of the downstream effects that this can have on care utilization, meaning people who receive palliative care tend to have fewer hospitalizations. When they are in the hospital, they tend to spend fewer days there, and they do tend to experience overall less burden on their caregivers. One common question that people ask me is, when is the right time for palliative care? When do I ask for it? My advice to all of you is that anytime that you are diagnosed with a serious illness might be a good time to think of palliative care. Certainly, we can be helpful with difficult symptoms, difficult decisions, and difficulty coping. And often I will say that if you ever start to feel like there are multiple domains of your life that are being affected by your illness, your body, your mind, and your spirit, that would be a really great time to think about how can palliative care support you and your family. Who pays for palliative care? Like any other specialty, like your neurologist or your cardiologist, it's covered by insurance as a medical specialty. And there are many kinds of legislative initiatives in California that are hoping to promote increased access to palliative care by requiring that people with a certain diagnosis actually have to be covered by public health insurance. Oh, let's see, I think my screen disappeared, but I'm back. Okay, how do I access palliative care? You can access palliative care by any kind of referral by a provider. That referral can come from your primary care provider. It can come from a specialist like your neurologist. And if you happen to be in the hospital, depending on your insurance plan, your inpatient medical team or the emergency room can also place a referral to palliative care. I like to just take a second now to say, to clarify something very important. A lot of very well-intentioned and well-educated healthcare professionals will often confound palliative care and hospice and assume that they are synonymous. So I'm glad all of you are here to help me spread the word and to make sure that this kind of misinterpretation, gets clarified as soon as possible. While all palliative care specialists are trained in hospice care, hospice is only a small part of what the broad field of palliative care hopes to provide. Like we just said, palliative care is a field that focuses on quality of life. That helps with coping for both an individual and their family. And it is available for people at any age and any stage of illness. Hospice, in contrast, we will talk a little bit now, is a small part of palliative care, but a very important one. So what is hospice? It is actually complicated to explain because it is actually three different things. Hospice is a philosophy of care, it's an insurance benefit, and it is a set of services. I'll take you through each three now. Hospice is a philosophy of care. First and foremost, has a philosophy of comfort-focused care. That means that hospice is focused on providing medical interventions through medications, through different interventions, through nursing help that is meant to help someone feel more comfortable and live more comfortably. Another major tenet of hospice is to deliver this kind of comfort-focused care in the place where people want to be, in the place that they are most comfortable, which statistically, for most people, is in the home. Hospice is an insurance benefit, so it's covered by nearly all insurance plans, including Medicare and Medicaid and Medi-Cal. As a part of its eligibility guidelines that are passed through by Medicare, two doctors have to assess that more likely than not that someone has a prognosis of 6 months or less in order for them to qualify for hospice benefits. Hospice primarily covers treatments that provide that kind of philosophy we were talking about, the comfort-focused care. If hospice is working with an individual and seeing that they're uncomfortable for any reason, they will do anything that they can in their power to make sure that they are comfortable. However, if we're thinking about a medical test or an intervention and we're not entirely sure that it does provide more comfort, hospice will usually recommend stopping that intervention or that test. Hospice, as a set of services similar to palliative care, has an interdisciplinary team. There's a doctor, a nurse case manager, a social worker, chaplain, volunteer, and home health. They all were part of the hospice team. I will say that in general, the lead member of this team is usually the nurse. So the hospice nurse, once you're enrolled in hospice, will usually come to the home at least once a week, if not more often. And she or they can come as frequently as needed, really to make sure that symptoms are as well controlled as possible. Hospice, as we said, is not necessarily a place, but certainly aims to provide care for the place, in the place that people are most comfortable. For many people, that does happen to be the home. Hospice provides a 24-hour phone line, meaning that hospice hopes to become someone's 911, where if there's any kind of discomfort or any kind of issue going on at home, you can call at any time of day, or weekday or weekend, and reach a nurse to figure out what can be done in the home to make that person more comfortable or help the family figure out what the next best step might be. Hospice takes over providing medications for symptom relief. They provide all medical equipment, and there's a whole host of other hospice services that I can certainly answer if people have more questions. To wrap us up, I just wanted to take us through, a few resources. We're very lucky in the Bay Area to have a lot of amazing palliative care programs. And this is not an exhaustive list. There are definitely more than just the ones listed here, but I bring them up to show that there are a lot of different options. There are palliative care programs that are located in academic centers, certainly at Stanford and UCSF, but there are also, public hospitals and safety net options as well. For anyone who might be thinking about getting someone connected to palliative care who may not be living in the Bay Area, I have a link for you at the very bottom, getpalliativecare.org. This is a national organization on the Center to Advance Palliative Care that creates this resource, getpalliativecare.org, for anyone to use. You can plug in your zip code and find a palliative care program near you. Here are some more helpful resources for palliative care. Our Stanford website certainly takes people through the members of our team, and there's some national organizations that I've also put on there as well. And again, for identifying a palliative care program close to you in your zip code, getpalliativecare.org. I hope the take-home message that you all have today is that palliative care is really here to partner with you, as well as your family and your neurologist in carrying the load. If you feel that you're facing a difficult road, just know that palliative care is here to help you support those symptoms and help you try our best to help with your quality of life. I also wanted to just end with a brief moment about the Stanford Neuro Palliative Clinic, which I've been developing at Stanford for the past year or so. The goal of this Neuro Palliative Clinic is to provide and promote interdisciplinary palliative care for people living with serious neurological disease. Certainly that includes anyone with a diagnosis of Parkinson's disease. We can see people virtually or in person, and it's available to anyone who's connected to the Stanford healthcare system. The referral that you can ask from any provider within the Stanford healthcare system is a referral to palliative medicine at this address, 213 Quarry Road. If you Google that address, you'll see it's actually the Neuroscience Health Center. It's the clinic that some of you are familiar with. And the referral, like I said before, can be placed by any provider in the Stanford healthcare system. So that includes your neurologist and also your primary care provider. Thank you again all for having me here today. Thank you to Robin for inviting me back. And I'm happy to take as many questions as people have. Let's see, I have the chat open and I can,
Okay, great.
yeah.
Thank you very much, Dr. Jiao. Appreciate it. Wonderful talk. We had a question, what are palliative care services in South San Jose, Morgan Hill, Gilroy? I referred people again to that getpalliativecare.org link. Is there and I
Mm,
mentioned Sutter, UCSF, Stanford. Are there,
mm.
maybe you want to put that slide back up?
Yeah, I will do that right now. There we go. Yes, it does not go quite south, this
Yeah.
map, down to Gilroy or Morgan Hill. But I believe there is a Sutter further south that definitely has palliative care. So if you have a primary care within that area, if you have a primary care provider, they can usually try to refer you to a palliative care specialist. I will say, like many specialists, right, like many neurologists, specialists tend to be crowded amongst urban areas. So like other specialties, palliative care tends to be more available for people living, I think, in more populated and urban areas. So sometimes that does, to see a specialist, it does mean traveling to a more centralized area. But the lovely thing about many palliative care teams, and mine included, is that we do a lot of telemedicine to try to make sure that as many people as possible can access the services.
So would somebody say living in Morgan Hill area need to be seen once in person at Stanford and from there on you could do telemedicine? Is there any rule about that?
Yeah, there's actually no rule whatsoever. There are many people who follow the Stanford Palliative Care team who never come to see any of the providers in person. So
Okay.
all of your care can be purely telemedicine. For my purposes, because I'm developing this neuro palliative clinic, sometimes there are some questions that are better answered in person. And then sometimes people will ask me, since I'm a Parkinson specialist, hey, like, what do you think about this weird thing that's going on? And could you examine me? So I actually happen to see a few more people in person for that reason. And certainly people living with Parkinson's disease, sometimes because of the softening speech, can have a little bit more difficulty interacting in telemedicine and communicating and having their wishes known. So sometimes they find it preferable or easier to see me in person. So definitely like to emphasize that virtual and or in-person visits are possible depending on what works for you.
Okay, and if somebody does want to come see you related to the information on the slide, bullet item number 3, do they have to be a Stanford healthcare patient then? They have to be seen somewhere at Stanford Healthcare.
Yeah, I think that's a very good question. So thank you, Robin and Denise, for highlighting that. So in the past, honestly, when I was first growing this clinic, we weren't really sure how many people would be interested in it. So there might have been a time when I could see people outside of the Stanford healthcare system, but that's not likely to continue because there are so many, people within the healthcare system, within neurology at Stanford, who are requesting access to the Neuro Palliative Clinic. For now, we are only available to people who are connected to the Stanford healthcare system. We're not able to take outside referrals at this time.
Okay, and so that means that in addition to having a medical record number, somebody has to have a physician who can refer them to neuropalliative care. Okay,
Exactly.
all right,
Exactly.
great.
Mhm.
Let's see. And so to make if somebody qualifies, that meaning that they're a Stanford patient, um, do they call palliative medicine or do they call movement disorder clinic to get an appointment or how does that
Yeah.
work?
Or to see me in my palliative medicine clinic, so really to see me in that context I was talking about with the full team, to meet the palliative social worker, to make sure the chaplain is there for you to get that kind of interdisciplinary holistic support, I would recommend a referral to palliative medicine. Of course, many people who I happen to see in my movement clinic, I'm utilizing like that palliative approach that I talked about in this talk. So in those cases, I might be doing a little bit of both in either clinic. But I like to tell people if your real hope is to kind of take that big picture approach and really think about quality of life in this expansive and holistic way, then I think the palliative medicine clinic is kind of set up to support that, whether that's with me or another palliative care provider. Some people I know, I've gotten a couple referrals recently from outside of Stanford. So I wanted to highlight that there's actually another neuro palliative clinic at UC San Francisco for people who are further north, can't make it down the peninsula, or who happen to already be plugged into their healthcare system. And if anyone has any interest in seeing that provider, I work with him closely. He's lovely and wonderful. His name is Dr. Kwame Ajipong. So UCSF also has their own kind of neuropalliative clinic growing. It's definitely an emerging subspecialty within these two fields.
Okay, great. We just had a Parkinson's caregiver support group meeting yesterday, or one of the many that we host. And a couple of questions came up related to that, and I'll ask one now till we get to some more questions. So somebody asked about getting kicked off of hospice or getting kicked
Mhm.
off of palliative care. Can you talk
Mhm.
about whether there is such a thing as getting kicked off of palliative care
Mhm.
and how one could get kicked off of hospice?
Yes, I think that is a great question because I think I see a question from John also that here, I'll just read it out loud. You said insurance won't pay for palliative care unless the patient has 6 months to live. Yes. But with PD, we never have such a definite prognosis. So what criterion does insurance use to authorize palliative care for PD? So I think, just to talk a little bit about this 6-month prognosis in general. So palliative care, just to reemphasize, does not require that you have 6 months or less to participate with palliative care. That was a little bit circuitous, but so basically with palliative care in my palliative clinic, I can see people at any age and any stage of illness. So that means I can see people when they are newly diagnosed with Parkinson's disease. I can also see them throughout any point in time when they might be experiencing progression or experiencing any major challenges to their overall health. And certainly I am very happy to see people when time is growing shorter and they are reaching the end of life. So insurance doesn't usually create any barriers or create any criteria by which someone can qualify for palliative care. I will say that there is some nuance to that statement in that many palliative care teams were born out of the cancer world. So many palliative care specialists, this is rapidly changing, but many palliative care specialists are more accustomed and comfortable with addressing the needs of people living with, say, cancer than other conditions. This is something that is rapidly changing in our field, and certainly I hope to be part of the front edge of that field change and that paradigm shift. But some people have told me that they did try to access palliative care at a different institution, and they were told, okay, this palliative care team does not actually work with people living with a neurological disease. They only see patients with cancer. So that is one instance in which I can imagine someone hearing that they were not able to access palliative care, that they were actually told that by a palliative care team. When it comes to hospice, so hospice has its own, here I'll go back a little bit, criteria to help them identify who is a good candidate and who is eligible to receive hospice benefits. This eligibility criteria and guideline is a hot topic of controversy in the palliative care and hospice kind of academic world. There are many people who point out that the hospice criteria that were developed for people living with, say, Alzheimer's dementia should not be applied to people living with Parkinson's disease. So certainly, there are a lot of people that I agree. Often we'll hear from hospices that they're not entirely sure if they qualify, because the hospice might be using criteria that don't really apply to Parkinson's disease. However, I will say that as like a neurologist, and a palliative care specialist, often that means that I will try to reach out to a different hospice agency to also reach out to a different hospice medical director to have a conversation if I think someone does qualify for hospice, and to advocate for them to receive services. Hospice has its own regulatory processes. So that means that every 60 days, when you're enrolled on hospice, the hospice agency has to justify to Medicare that you are still likely to have a shortened prognosis, that they're still kind of meeting the needs of people who need specialized care who are reaching end of life. So sometimes hospice agencies, unfortunately, if they are not able to justify that someone is reaching the end of life, say if you happen to enroll in hospice and get better, then they have a term for that in which they will graduate people and say basically hospice is here for you in the future when and if things shift again. But right now, they're not able to provide the services. And I've, walked families through every side of that transition back and forth, and it can be a time of, a lot of upheaval. And all I can say for the person asking the question, the caregiver out there, is say that you're doing the absolute right thing by advocating for your loved one. If you feel like they are really benefiting from hospice and they really are, receiving so much support, and at this time when they want comfort focused care at the end of life, then you're absolutely doing anything, all the right thing by advocating with the hospice agency. Though I do know that it is an unfortunate reality that sometimes people are not able to keep the services if they start to get better.
And similarly, is there any circumstance under which somebody could get kicked off of palliative care? Is there any sort of
Mhm.
care or treatment that someone would receive that would disqualify them from palliative care?
There is not any kind of treatment or intervention that would necessarily disqualify anyone from receiving palliative care. I will say with my own patients, you know, and our own team, our team is really there to meet the needs that exist. So for many patients and families, there might be, a point in time when we all take a step back and say, hey, like it sounds like a lot of the needs that we identified when we first met have been addressed, or addressed to the best way that we can imagine. And certainly I always tell people in my clinic, I never want us to be another team that you feel obligated to check in with. Right? There are so many doctor's appointments that people have to attend, and therapy appointments and speech therapy and so on. I never want, your palliative care visit to be burdensome. So if you feel like we are accomplishing something that's meeting a need for you, then I am happy to continue to stay in touch. However, there might be a point in time when you realize you don't need me anymore. And that's all good news to me. That means that, we've accomplished something, or we've moved the needle. And that your quality of life is in a different place than it was when we first met. So I never take that personally. And I always say, that if you ever graduate from palliative care, it'll be because you told me that the services, that you didn't have a need for the services anymore.
At the present time. Yeah,
Mm.
that's great. Okay, thank you. Another thing that came up at yesterday's caregiver meeting was, and I don't know how much you know about Kaiser, but I imagine you know a little bit. So in this case, a person had it was a caregiver of somebody with Parkinson's disease, advanced Parkinson's disease. Person was bedbound, not able to communicate, and perhaps significantly for hospice qualification, the person is regularly losing weight despite still
Mhm.
eating some. So the prime person they're seeing at Kaiser, and the primary care physician said that she would not prescribe or advocate for hospice because she didn't feel that it was warranted. Do you have any suggestions for what the family might do if the family, I guess at Kaiser, the primary care physician is sort of the
Right.
gatekeeper to everything. So what might they do? I know with Kaiser, for example, they don't have to use Kaiser hospice. They could use another hospice.
Yeah, and the honest truth is that a lot of hospice agencies take self-referrals. So even though the referral process usually works as in you have a doctor or a provider refer you to a hospice, a lot of hospices will also take self-referrals. So if you deeply feel that your loved one, is at the point that they would benefit from hospice, that is a path that you can take. The other thing that I might give some advice for is that, especially if you have any other doctors in the Kaiser system, right? It can be any doctor who refers you to hospice. Similarly, any doctor can refer people to palliative care. Um, and I do understand, the Kaiser system, right? Usually the primary care doctor is the quarterback, the coordinator for all of the care. And if all those other kinds of suggestions don't really are options for you, I think, just, having another conversation with your primary care doctor to say, hey, these are the things that I'm really noticing and that I'm worried about. And I'm worried that time is growing shorter, and I want to make sure that my loved one has enough support. Like, what can you share with me your own thoughts? Can we set up a time to talk? Because
Mm.
it might be that that primary care doctor has certain concerns about, the kind of treatment that you might be getting that might not, for example, be paid for by hospice, right? They might have some sort of other reason that they are, hoping to continue with care that's outside of hospice. So it would be good just to kind of set up a time to hash it out.
For getting back to palliative care, neuropalliative care, does insurance then, say Medicare, does it cover people seeing a social worker or chaplain, these kinds of non-MD specialists?
Yeah, so I think that's a really good question. I will speak for the Stanford palliative care team. Um, because I do think that uh billing works is a complicated beast. It works a little differently at every institution. The interdisciplinary team members, as part of our Stanford palliative care team, do not bill for their visits. Only I do, as the medical provider. That means when the social worker and the chaplain join me in my palliative care visits, I'm the only one billing, and they are there to kind of participate and to help support the patient and the family in that time that they have. Any one-on-ones that they schedule with the patient and family, which they frequently do, are not billed for either. So for example, a very common scenario is that I might be working with a caregiver, a care partner who's really experiencing a lot of strain, really having, experiencing anticipatory grief and wanting to process some of that emotional upheaval with someone. And the social worker will set up potentially a one-on-one phone call with them once a month, once every month, other month, just to check in. And those regular check-ins are not billed for.
Mhm. Okay, thanks for explaining that. Does anybody have more questions? Do you want to read the next one,
Yeah, I
Jocelyn?
can read that.
Can.
From John, I think comfort focused care sounds good for those of us who've had PD for quite a while, such that it very much affects our quality of life, even though we probably, hopefully, have many more years, not just months to live. Yeah, I think, it's really, sometimes I think, this is my hot take, a shame that for many people, in the United States, that our medical system really has this 6 months or less label, or this kind of gate at which people can, enroll in hospice or not. It's not necessarily that way in other countries. For example, in Canada, there is no prognosis requirement associated with hospice. So what I will often tell people is that even if you don't qualify for the services, that set of services that hospice provides, I think it's entirely reasonable to make sure that your own goals and values are the things that are driving the type of care you're receiving. So in a way, we can enact a hospice plan of care, even as your neurologist or as your primary care doctor. We can say, hey, these are the things that are most important to you at this time. It's your quality of life, freedom from symptoms, whatever that may be for you, making sure that, we focus on in the moment and maybe deferring tests, right? Or other kinds of diagnostics or other kinds of interventions that are not likely to benefit you as much or just don't really fit within your goals. So I think it's entirely possible to have a comfort focused plan for the entirety of your life if you wanted to. I think it's just a matter of weighing these different interventions when they do pop up, when they do provide the potential for prolonging life, right? And thinking, does this fit within kind of my schema? Does this fit within my expectations and my hopes and my worries of what my care plan will focus on?
One other thing that comes up quite a lot in our caregiver support groups is especially when a person has advanced stage Parkinson's disease, they may be experiencing urinary tract infections or
Yeah.
pneumonia with perhaps more frequency than they did when they were um, less debilitated. And these kinds of infections are far more dangerous at that time.
Mhm.
One thing we talk about in the caregiver groups is whether these infections should be treated with antibiotics or
Mhm.
not, or whether they always cause pain or not.
Mhm.
What kinds of things do you discuss with families with respect
Yeah.
to infections and treating infections?
Yeah, that's such a good question. Thank you for asking that, Robin. So infections are a big topic in my neuropalliative clinic. Um, Infections, especially recurrent ones that kind of keep coming back, like you kind of tamp one down and then another arises. I kind of liken it to a game of whack-a-mole, or one thing, no matter what, seems to be arising. They can really create so much, I think, stress and anxiety and pain for people, especially if the infections are serious enough that people are coming back and forth to the hospital, and getting tests and getting more treatments and so on. So, one important question that, conversation that I have with some families is um, thinking about the end of life in Parkinson's disease, and what does that look like? What do I expect to happen? And one thing that I, explore with people, with their permission, are these kinds of clinical scenarios that often tell me as a specialist that time is growing shorter. Um, and knowing that time is growing shorter, no matter what we do, right? No matter how aggressively we treat them, what's most important? Um, if it comes down to the question of whether to treat with antibiotics, I will just say this. I want to clarify for this because I know it's a common misconception. Hospice will use antibiotics. So they will test for urinary tract infections. They will even treat them with oral antibiotics. Because there's a lot of argument to be made, that if people are just sleepier and less interactive and less able to participate in their day-to-day life, then their quality of life is probably not as good. So hospice, if they are able to identify a urinary tract infection because someone's just symptomatic from being more sleepy or more confused or more out of it, they will actually, like I said, test and treat it. So it's more that thinking about the kinds of more hospital-based interventions that people might need when they get a serious infection. Um, because those really do fall outside of that kind of comfort-focused philosophy, hospice is less likely to do. So from my perspective, often I have a pretty low threshold to say, hey, like it's similar to hospice agencies. If treating with antibiotics you think helps with quality of life in this moment, then I'm on board with that. But also let's talk about what this means. Okay, let's talk about the fact that we might be entering a different stage of Parkinson's disease. And we know that in Parkinson's disease, one of the major pathways that people reach the end of life is through these kinds of recurrent infections. So what's most important now that we're here? And how do we want to use this time? What do we want this time to look like? Where do we want to be? It's mainly kind of an entryway to that kind of bigger conversation.
Okay, and similarly, I would imagine you would use the same kind of probing questions with a patient and the family, if when it comes to whether or not they want a feeding tube or
Mhm.
this, because swallowing is often very problematic in Parkinson's
Yeah,
disease.
yeah. The literature on feeding tubes in Parkinson's disease is vanishingly small,
Mm.
meaning that there are very, very few studies out there that actually have that to give doctors guidance about whether to recommend them, when to recommend them, what the real risks are. We do know that for all comers of people living with dementia, so not just Parkinson's disease, all people living with dementia, feeding tubes do not prolong life, nor do they improve quality of life. Because of that, because of those big studies, there are some doctors, especially some, surgeons who will say that they don't do they don't do this procedure. They don't place feeding tubes because they don't believe that there's much benefit to be gained, only risk. I will say, however, when we sharpen um, the telescope to just looking at Parkinson's disease, I think there's more nuance there. So I've worked with people that, swallowing was really, something that was impacted when their quality of life was still relatively good, right? And so we kind of talked through the pros and the cons and also talked through the important question of, is there ever going to be a point when you grow sicker, when you grow closer to end of life, that you'd want us to stop using the artificial tube feeds, right? And as long as we have that kind of conversation up front, then I think that, there's not, a huge reason not to think about a feeding tube. In many other situations, it might be clear to me that someone's, developed swallowing issues and they're also in and out of the hospital for infections, and also they've stopped communicating, they're spending much of their time asleep. And then the big picture is different, right? The big picture is really, we've reached the end of life, right? And the swallowing, it's just one sign of that. And in that case, knowing that an intervention like a feeding tube can also prolong the dying process for people, I usually recommend against it. But
Mhm.
like I said, it's all recommendations. It's all based on the person and their family, and they're all in their own individual goals and hopes. So there's no right or wrong answer. It's a nuanced conversation to have.
Yeah. Since you've been at Stanford now 2 years?
Just over a year.
Oh, okay. All right. I imagine you have had patients with Parkinson's disease on your palliative care service for this entire time. But do you have any expectation for how long somebody with Parkinson's disease could be on palliative care? Could it be years and years?
So I'll speak for myself, and then I'll speak for the fact that other teams may operate differently. So for many of the people with Parkinson's disease that I see in my palliative care clinic, many of them do have advanced Parkinson's disease, and I am managing a lot of different symptoms. or really addressing a lot of caregiver concerns, and really helping people kind of navigate a lot of complicated decisions, much like the feeding tube decision we were talking about. So in that period of time, there's a lot to discuss, right? There are a lot of needs. And for many of those people, especially when they are at that stage in which there are a lot of needs, I will follow them until the end of life. For people who are that newly diagnosed, I think of my role as a palliative care provider, it's my job to think of the ways that we can really try to support them to help them adjust and adapt to a new narrative, a different kind of life trajectory that they were thinking about. And just thinking about like looking ahead and helping them make sure that they feel supported and nourished and prepared in the way that is most beneficial for them. So for someone who's newly diagnosed, I might meet with them intensely as we were getting that all set up. But in that kind of similar to what I was saying before, they might end up telling me at some point, actually, I think, I think I'm good. I think that things have, leveled out and I have reached a place of, acceptance and I know what the resources are. So I usually tell them, I'm happy to see you back whenever things might change in the future. As we know in Parkinson's disease, things always do change.
Mhm, mhm.
So it's an open door to come back and forth depending on the need.
Okay, that sounds wonderful. One of our attendees mentioned a study done by Maya Katz when she was
Mm,
at UCSF, looking at a whole team approach, whole care team approach. Maybe you could mention that
yeah,
study
so
and findings.
yeah, Maya Katz, one of, probably the real parents of neuropalliative care. She was part of the wave of doctors that really introduced and developed it, especially at UCSF. And she was at Stanford, and yes, is correctly on leave currently. And yes, the study that Maya and her collaborators ran was the exact similar model to the study that I showed, which is comparing two groups, one group receiving integrated outpatient palliative care for people living with Parkinson's disease versus people who did not receive it. And the findings for that study are really interesting, really, really powerful. I can share that PubMed link with you, Robin, if you don't already have it saved somewhere.
Oh, yeah, yeah.
Um, and it showed a lot of the same kinds of outcomes: improved symptom burden, decreased caregiver burden for people who in the palliative care group.
Yeah, I think the first the study you talked about in one of the slides near the beginning, it is really amazing what a huge difference being on palliative care makes to someone's longevity.
Yes, I
Yeah.
think that was that was an inflection point in the field, in which people in the palliative care world were able to kind of prove that whatever they provide in the palliative care syringe, whatever is delivered through this intervention, not only helps people with quality of life, which of course is vitally important, but even helps prolong life. Because, and we can speculate all the reasons why that might be the case. But yes, that was a very important and powerful study.
Yeah, and no doubt effects for the whole family system as well,
Yes,
reducing caregiver stress
yes,
and
yes.
family stress
Yeah,
overall.
yeah. So we know that caregiver burden is a huge um cost to our entire social system. Right? People
Hmm.
who are caregivers have worse health outcomes, are less able to remain employed in the place that most that they find most meaningful and productive. And so addressing caregiver burden and making sure caregivers are supported as much as possible is a major goal of palliative care.
Okay, wonderful. All right. Well,
Right.
yes, we'll send the reference to the paper. We'll send a recording of Dr. Jiao's talk today and her slides, and we'll post all of that information plus the information about the previous research study that Eva and Daria spoke about as well. So thanks everyone for joining us, and thanks again, Dr. Jiao, for doing a great second talk to our group. Really enjoyed it, and it's always great to hear from you.
Thank you, everyone. Thank you, Robin.
Bye-bye.
Have a good day.
Bye-bye.
Bye-bye.
Bye-bye.